I'll call upon Dr. ARUN Kshetrapal, who's going to talk about cataract surgery in post-RK patients. I'd like to share with the audience that in Ajmer, we have got hundreds of cases who have undergone RK surgery couple of years back at Indore, and now they are in trouble as far as their IOS surgery is concerned. So let us see what Dr. ARUN Kshetrapal has to share with us.
Morning everyone, I'll straight away go to the point. We all know that RK was a popular corneal based refractive surgery for correcting myopia way back in 80s and 90s. In which there was a near full depth radial incisions were given on the cornea, leaving a central 3 mm zone, and as a result of these incisions the central cornea will flatten and resulting in myopia correction. So basically there are three challenges which come in patients coming with cataract who have been operated upon earlier for RK. There's a difficulty in achieving post cataract surgery target refraction, and there's a decrease in corneal integrity from the compromised incisions because of those RK incisions, and there's an instability of refraction, and there's a continuous hyperopic shift even after 10 years, 20 years. So there's a continuous hyperopic shift. So errors in IOL power calculation are basically because of three reasons. One is keratometric index of refraction for the cornea doesn't holds good now because of the change in both the anterior and the posterior corneal curvature. There's a difficulty in measurement of the corneal power because there's a flattening of the central cornea, and most of the instruments they measure the paracentral corneal power and they extrapolate the central corneal power. So there's error in corneal power measurement and misleading ELP or the effective lens position, because again the central cornea is more flattened as compared to the paracentral cornea. If you can appreciate in this OCT, not only the anterior surface of the cornea is altered, but the posterior surface of the cornea is also irregular. This is a case of RK, a patient who has undergone RK. So preoperative evaluation would basically include a good history of taking, if available, the preoperative K values and refraction. Slit lamp examination basically aim to know where are the all RK incisions, and you plan your main port incision, the phaco incision there and there on the slit lamp. Since these patients may be hypermetropic right now, but they were myopic earlier, so you need to do a detailed fundus examination and a good corneal power calculation. Basically, we are using Scheimpflug imaging, which measures both the anterior and the posterior curvature of the cornea and gives us the corneal power. However, you can use an OCT based tomographer which measures both the anterior and posterior corneal power, such as ARUN or MS39, but they are pretty expensive. We usually aim for minus 0.5 to 1.5 diopters of myopia after the surgeries to compensate for future hyperopic shift and to address the issue of overestimation of corneal power. The IOL power calculation formula for our choice is Barrett-Trouquet, because it takes into consideration both the anterior and the posterior curvature, and usually the history is not available, so either we go with Barrett-Trouquet, no history formula, and if we feel that there is an astigmatism on the cornea and we can deal with it, so we may use Barrett-Trouquet toric formula. So this is available online and you need to fill in all the values, and here just for you that you need to click on to the radial keratotomy here and then feed in all the values, and it will give you the IOL power, and if you have chosen a toric calculator, it will give you the position of the toric IOL as well. Alternatively, you can go to ASCRS online IOL calculator, and wherein you will need to click this prior RK and feed in all the values, where as much as you can feed in, you don't need to feed all the values, and it will give you the IOL power calculation. But my preferred IOL power calculator is the Barrett-Trouquet. And which IOL you would implant? I will go in for a negative aspheric IOL. Monofocal negative aspheric is my choice because the cornea is oblate now and you need to compensate for this plus Q value. If the astigmatism on the cornea is regular, you can go in for a toric IOL, but rarely I go in for a multifocal IOL in these cases. I'll skip this and I'll directly come to the intraoperative considerations. since there are chances of dehiscence of the previous RK incisions intraoperatively, you must be very careful and place your main port incision in between the two RK incisions, and you can either place them slightly posteriorly or even go in for a scleral tunnel. Intraocular pressure is kept low throughout the surgery, and we do not overfill the with viscoelastic, because these RK incisions may give way, and if they give way, we may even suture them. So here is a surgery. So there's only 4 RK incisions. We have ample space for our main port incision, so we don't alter our technique in such cases. So you make your usual incisions wherever you want, because there's an ample space between the 2 RK incisions. In the next case, there's an RK incision temporally, so you need to improvise your main port incision and shift it slightly inferiorly so that you don't intersect the RK incision. So you may have to improvise your incisions. Here, if you can appreciate that while putting in the lens, the RK incisions gets opened up, there's a dehiscence of it. So after implanting the IOL, I'll try and see if I can manage this by just stromal hydration, and I was successful in this case. After proper stromal hydration, the wound got sealed up and there was no leakage. Sometimes the reverse can happen. All the incisions are closed, but the moment I hydrate the stroma, the incisions open up. So you have to be very, very careful while hydrating the incisions. Here I am trying and going slightly scleral so that I don't open up the incision. There was no space in between the 2 RK incisions, so I have to go slightly scleral. And after the surgery, when I close, you can appreciate that all the incisions are intact, which were traversing the main port incision. And if your incisions open up, you need to suture it. Just apply a suture. There's no harm in putting up a suture, which you can later on close this. You can later on remove this suture. So in conclusion, to minimize post-operative hyperopia, use a corneal tomographer or a good system to calculate the corneal power, and aim for -0.2 to 1.5 diopters of myopia post-operatively. Intraoperatively, it is of paramount importance to decrease the possibility of RK wound dehiscence by avoiding the intersection of the main entry incision with the prior RK incisions and preventing high intraocular pressure during the surgery. Thank you very much.
Thank you, Dr. Arun, for nice presentation. My question to Samresh, can we put multifocal or EDOP lenses in such cases?
Intrascleral, if the capsular bag is, no, I would not advise. No. Because despite on the table seeing that these lenses are centered, when we did a UBM, there is a slight amount of tilt.
No, I talking about the RK patients.
RK patients. RK, sir, if the topography shows regular astigmatism in the pupillary area, I may counsel them for an EDOF lens.
Yes.
Not for a diffractive.
So
what is your experience, sir?
We do EDOF, lot of EDOFs in these patients. Again, the cornea should be regular. Even if there's a regular astigmatism and we are able to identify the major axes in astigmatic cornea, we go ahead with the EDOF toric. Multifocal we try and avoid for the obvious reason. There's a loss of contrast sensitivity, etc. in these cases. And if the cornea is irregular, multifocal is a big no.
Do these patients continue to have optical aberrations in their regular routine life?
Yes. Once the corneal abrasions, they'll stay with you forever. You can't do much about it, and it's better not to touch these abrasions and not to correct them with laser. Yeah.
Ks are so flat sometimes. They're at 28, 30, 32,
30,
especially in the
30
major RK. So it's better to tell them that it is their problem and show them the topography. Because despite our surgery, I don't think we can give them some of them a great outcome.
Right. But 4 cuts, 8 cuts, they do pretty well. I have a lot of cases, 8 cuts, in whom I have implanted torics, EDOF. They had very good vision and they are maintaining good vision post-operatively.
That's wonderful. Thank you once again.
Mic is on.
Not coming?
Yeah.
Okay. So my concept is that RK patients are having multifocal on the cornea. Even many of the monofocal patients, they have 6/9 and N6 or N10 kind of vision. So no, there is no place for multifocal. Definitely EDOF have a place.
Yes.
And advanced monofocals, they give majority of the time good vision.
Right.
The another thing, as Samresh has sent out, that the patients may be having 28, 30 or 29. And it is very rare that you will end up in emetropia. So just promising multifocality without a concept in your own that emetropia will be there, I think it is not a good thing.
So-
Because you will have a problems more often than actually not having a problem.
So in patients who have lot many cuts, maybe 16 or something, we even counsel them for that you may require a lens exchange after the surgery. And in some cases, we even do a two-step procedure wherein first we create aphakia and after a week or so we do a refraction and then we implant the lens.
That is one good approach. And my choice of preference for IOL formula is you go on scrs.org and choose the post RK formula and feed in the data of the pentacam also.
Pentacam, yeah.
That
So-
is very, very important in these patients. As somebody was just saying, anterior and posterior curvature. The anterior curvature, posterior curvature concept remains, the posterior curvature remains same in the post-laser surgery. But in RK, the whole overall cornea becomes flat. So anterior and posterior curvature both changes.
Both the anterior and the posterior
So,
curvature changes. in
Better
post-
to feed in both the datas and then you will have more predictable results. And still you should aim, as you correctly said, for myopia rather than emetropia.
Amen.
With this, we come